Everybody, this is the 64th meeting of the Council of Governors of Oxley's NHS Foundation Trust, and you're all very welcome. Can we start, please, with any apologies for absence? Jo Mant, please.
Thanks, Andy. We have apologies from Janice Algar, Zara King, Carl Crowhouse, Cara Lee, Francis Murray and Steve Pleasance.
Thanks very much. If we go to the minutes of the last meeting, please, sing out anybody who's got any observations. Page 1, page 2, page 3, 4, 5, 6, 7, 8, 9 and 10. If no observations on that, please accept them as the minutes of that last meeting. Any matters arising from anyone that are not included in the rest of the meeting? I can't see that from anyone. We now move on there to the NED nominations committee. Jo, if you withdraw for the moment, please, Jo Stimson and Sally. I take it you've got Jo's contact. We want to call her back.
Yeah, I can do that.
Okay, thanks very much. Right, Sue, do you want to say anything on this one before I do?
Very happy to be involved in this process and delighted with the appointment. Now she'll let you make the announcement.
Okay, right. I have to clearly ask the permission of the authority of the Council of Governors for this, but it's Jo Stimson's coming to the end of her second term in office, which ends on the 30th of April. We undertook a survey, as you can see from the paper, asking for feedback from NEDs and other members of the board and the Council of Governors, and a 360 appraisal was carried out as well. I think Jo has been, and then with this, there was then taken to the nominations committee, who recommend that she be reappointed for another 3-year term. I think Jo has been outstanding. She chairs the business committee. She chairs our partnership committee. She's involved in the mortality committee. She's now our senior independent director. She has been a source of excellent counsel and guidance on all matters, but particularly those to do with business and finance. And I think it's forged a very good relationship with the executive and with her fellow NEDs. She gives far more value than what you pay her, as do most of the NEDs. We employ them for so many days a month, and they all exceed the amount of time that which they're paid. I'm very happy to answer any questions on Jo, but my recommendation, the recommendation of the nominations committee to the Council of Governors, is that she be reappointed for another 3-year term. Does anyone have any questions at all, please? If not, then it's a matter for the Council of Governors to agree with it or disagree with that recommendation. And I'll be looking for waves of hands and nods. Do we all agree that Jo Stimson should be reappointed for another 3-year period? Lots of waves, lots of yes, well done. Thank you very much. Thank you. Yeah. Sally, therefore, sorry, Victor, please.
No, I'm not objecting, just raising my hand in support.
Ah, jolly good. Oh, thank you. Thanks, Victor. Yeah. Right, okay. If we're all agreed, then Sally, please invite Jo back in. Thanks very much.
Thanks. I'll get in touch with Jo.
Okay, thank you. Now over to item 5. Iffy, your report, please.
Thank you, Chair. And I don't intend to go through my written report, but a few things that I just want to draw attention to. The first, of course, is I'm really delighted to announce the appointment of Dr. Abi Falipe as our Executive Medical Director. Many of you know she's been at Oxley's for over a decade and was one of our deputy medical directors and consultant in OD psychiatry, looking after dementia inpatient unit, Holbrook Ward. So please, I invite you to join me in congratulating and welcoming her to the Council of Governors this afternoon, and she will be speaking later. Also, a very warm welcome, of course, to Sophia and Jim, who are with us now, and a huge congratulations to Joe. I'm really delighted, Joe, that you are going to continue for another few years, and also as a senior independent director. Joe clearly has contributed hugely to the work of the board. The exec value Joe, especially the wisdom and the support that she offers to us. Yeah, Missy, I'm not sure if I saw your hand come up there. No, okay. I'm also really quite pleased to confirm that the regulations to revoke vaccination as a condition of deployment has now come into effect. So a couple of days ago, it ceased to be law, and so we're all very pleased that that's behind us, and we can now get on with supporting our staff and rebuilding the workforce that we have, particularly the divisions that caused over the previous 3 or 4 months when we were working very hard to meet the deadlines. You will, of course, know that the government has lifted the COVID restrictions, but we're still receiving guidance from the government regarding this. You will not believe this. Someone's just come to my door in the middle of my presentation. Can I be given a moment, please? Just a moment. My apologies.
This is the joys of this, isn't there? Lots of advantages and disadvantages. And while we're talking about those, Sally has been putting around a survey. Sally, who's it gone out to, that survey about meetings for the future?
It went out to governors this morning, actually. So it's gone out to board and exec members and governors so that we can try and build on our experiences and work out a good way going forward.
Yeah, I think this is really interesting, because my initial thinking on this was let's get back to face-to-face straight away, but a number of factors which are in the preamble to the survey. I've got the floor at the moment. So I just hold it.
I know. I can hear that. My apologies.
But I just think we want to think about this. There are a number of factors. Even pre-COVID, we were talking about why is everyone all driving around Southeast London for meetings, and now you add to that the convenience, cost, environmental issues, the cost of fuel and all the rest of it, and time. I just think it's worth reflecting on how we get the benefits and the best of what we've done over the last 2 years, whilst when appropriate, getting back face to face. But anyway, that survey's gone out. Okay, I filled in some time there. Ife, and back to you.
But thank you so much for that. And John, can we take your question or comment when I'm done? Yeah, okay. So I was just talking about the lifting of COVID restrictions, but of course, guidance is still coming through for those of us who work in the NHS. The only thing to say is that our acute trust partners are seeing an increase in the number of patients testing positive and those presenting with COVID. And in fact, in Southeast London, only yesterday at the ICS executive, LGT and Kings reported an increase between 10 and 40% in the last 2 weeks alone. So we're not quite sure what this is about. There's a view that this could be as a result of a relaxation of the rules. There's another view that we may have a new variant that's coming through. And there is some speculation that the lateral flow test takes a bit longer to test positive. And so people don't quite know that they are positive until after they've infected many others. The good news for us in Oxley is that we have not seen an increase amongst our patients. However, there's been a slight increase in the number of staff who are absent for COVID-related reasons. Just a brief comment about pressure on services, which I will say is widespread right across acute mental health and community health, and this pressure continues. And in fact, we've got a meeting across London tomorrow of chief executives, and the main subject of discussion will be the weight that ambulances are experiencing when they get to acute trusts. In some parts of the country, particularly in the southwest of England, ambulances are waiting 4 to 6 hours before they're able to for handover of patients before they're able to leave. And then the final thing I just wanted to comment on or mention is the Ukraine crisis. We all see this in the news, both television, radio, and our phones, which no doubt is affecting quite a number of staff. And I just want to thank again my executive colleagues who have held listening events to support staff who are affected. And I've got to emphasize that these are not necessarily staff who come from either Ukraine or Russia. These are also staff who, for various reasons, are just affected by the news and the things they see on television. And so we've had the listening events, we're signposting staff to health and wellbeing resources, and we've shared information with staff that's come through the NHS about how they can support the people of Ukraine. And of course, many of us are really, really hoping that the peace talks will bear some fruit so that we can move past this horrible thing that's unfolding before our very eyes. So like I said when I started, I'll assume that my paper has been read, and I'm happy to take questions.
Nina, please.
Nina?
Sorry, were we going to come to John as well? Had you mentioned John before, Iffy?
Yes, John had his hand up, but it's gone down now. And John, did you want to?
Oh, I'm happy. Iffy, I was just going to add to your comment about the infection rates, really, because I think there's a real risk that the perception is that we can relax. And I see from students and I see from my colleagues at work, I think we have more infections now and more people off sick, and also in my teacher networks. And, you know, there's one colleague who's fit, able, and has become so unwell in the last 4 weeks. So I mean, we just have to keep our alert up, really. And that's what made me link it to Sally's, the survey about where are we going with meetings, really. So I urge caution. I mean, that's my...
Iffy, I was just going to come in on a related point, which was to ask if I'm seeing similar headlines to what you've outlined, but speculation in the press that it's now beginning to bite quite hard in those who are 70 and above, who have had their boosters now quite a long time ago. Where are we nationally on the booster rollout programme? And is there an update that you could give us on that, please?
Yes, so I think that the NHS is preparing now for the autumn to boost people who are 70 and over and those who are considered to be at greater risk. So that's the certainly the plan. In the meeting yesterday, one of the suggestions was that we perhaps go back to the national team and ask whether we need to bring forward an additional booster for NHS staff. So we avoid the experience we had earlier in the year, where lots of staff were absent and, you know, it became almost impossible to run services. So I anticipate that over the next month or so that something would happen to do with staff, but the over 70s are certainly, there are plans, but it may just be that those plans are brought forward and we don't wait until September, October time.
Cassandra, please.
Hello, just coming at this from a support provider angle. So we provide supported accommodation and support in Greenwich and also the forensic side of things. I just wanted to touch on the pressure that you mentioned on the mental health inpatient beds and just reflecting back that there have been sort of recent changes in how Oxley's has been organised in terms of directorates, and we as providers think that's having an impact on getting people out as quickly as possible. So previously, community teams and providers in Greenwich were involved in a regular bed management exercise, a weekly exercise where we could go through the patients who are on the ward and discuss their discharge plans and whether they needed supported accommodation, whether they needed assistance to get off. And we don't have that meeting anymore. We've raised it consistently with your Oxley's colleagues that are sort of at level and in the community, because we work most closely with the community teams, and they're also so similarly bemused as to why these have stopped. And I do think it's beginning to create a real issue with, you've got a lot of people coming through the door because there is a lot of demand, but I also think we're not moving people out quick enough. So it's an observation to you to wonder whether the sort of reorganisation has perhaps in some areas exacerbated that problem or created a bit more of a sort of logjam than you might have anticipated.
Thanks, Cassandra. The meetings have not stopped. I can tell you that. There are 3 meetings every day, and Dr. Farid Jabbar, I can see him right in front of me on my screen, is Director for Flow, and he will tell you that he's in all of these meetings every day. So I think that there's perhaps a disconnect because you work mostly with community teams, that you are not joining those meetings. But I think we will certainly make sure that you are reconnected to those meetings without any question.
And it's my understanding that the community teams aren't involved in those meetings. So in terms of sort of discharging people back to the community, that kind of makes it really hard. So we're sort of just not cited. So yeah, anything that can be done to improve that will definitely, I think, improve some of your discharge figures.
Yeah, I don't want to go on a witch hunt, but I'd be interested to know what community team is not part of that meeting, because they should be. There's no question in my mind about that, Okay, but thank you for raising that.
I'm just wondering, can someone catch up with Cassandra and just clarify the situation? Would be really helpful.
Yes, Farid has raised his hand that he will do that. Yeah.
Okay, thanks very much. Thank you, Cassandra. Any other questions for Iffy on his report? If not, then thanks very much, and we'll move on to Lead Governor report. Sue, please.
Thank you, Andy. I am presuming most people have had the opportunity to read it because it has been circulated, and but happy to take any particular questions if you have any. It's fairly straightforward about what the role of the governors are at the start, the various meetings that governors have attended over the last few months, and as we've already stated about being involved in the appointment process, and obviously, as you've heard recently, about Joe Stimpson, which is a really pleasure and an enjoyment to be in that. And I think the fact it's important that as governors, we do have the opportunity to have a two-way conversation with various meetings. And I know, for instance, certainly in the meetings I've attended, having the opportunity to send questions prior to the meeting at the board meetings and whatever, so we do get answers. And I have attended the ones that I have been able to, and the only one I missed in February, sadly, was the board away day, because I was actually away on holiday myself. But I do attend what I can and when I can, and I think it's important as governors we continue to have that link with people, because that's how we fulfil our role as governors. And certainly as a lead governor, I do take my job seriously. If you recall, we mentioned previously about the opportunity to have a governor's away day, and Andy was extremely supportive of that idea. And you'll see in the notes we put a tentative date out as the 25th of May, because that fitted in with Andy's diary, which I'm sure must be a nightmare, trying to attend everything and get to places. So trying to not tie him up in any more knots than he has to as the lead for the governors and for obviously what he does for Oxley. But if any people have any ideas as to what you'd like to be involved in that Governor's Away Day, it may be a half day. We're not sure yet. We've still got the final things to work out, and I'm grateful for Joe and Sally and Anne-Marie in helping us sort of looking at that. And one of the things might be part of that day is, if you recall, we talked about cyber security, not just for us as governors, but across the whole trust. But it was an opportunity to see where we're going with that. And I had a conversation with Joe recently about how we're moving forward on this. And it's trying to tie the gentleman down who does it, because he's extremely busy with everything else. And but it'd be very good, I think, because we're all aware of, of ensuring that our computers and our laptops, just in our own lives, let alone what we do for Oxley, is secure, and making sure we're not passing any nasty bugs on. One of the other things about looking at visits is we've got 2 visits. I think they're virtual, but hopefully eventually, as we already said, the survey that's gone out for meetings. And like Andy was saying, think carefully about it. And I've already answered mine. And I think it's, given everything else that's going on, listening to about the COVID rises in cases, perhaps we do need to have a mixture of virtual and face-to-face meeting. And certainly also, if we're trying to meet our environmental standards as Oxley's, as a trust, we might need to revisit how we do that, because otherwise people spent a lot of time travelling from one place to another for a meeting, and all that involves. So we've got 2 opportunities to visit services, one on the 25th of March, and that link's been circulated, and then one on the 3rd of April, which will be with Lorraine Regan, and that will be circulated. If you want to know any more details, obviously let Anne-Marie know. And if you've got any other requests regarding services, if you can let Anne-Marie know or let me know, and we can look about how these will work. And obviously at the moment they are still virtual meetings. But that's basically, I don't want to go on for too long, but if anyone's got any questions, I'll do my best to answer them.
Thanks ever so much, Sue, and thanks to you and all the governors for the amount of work you put in going to visits and committees and things like that. It's very, very much appreciated. John, please.
Thanks, Andy. Sue, I was wondering, in view of the informal meeting, when we made reference to the amount of, I guess, external events that Sally and Joe alert us to, whether your report could somehow just note some of these events. Because in a way, it would be really helpful to show how we're also externalizing as well as internal events, really.
That's a good point. We'll make sure that's on the report in the future. I mean, say Joe's very good at keeping track of what we get up to and where we go. And certainly, I know from what she circulated for the next members meeting, there's some outline in that. But certainly in terms of what we do as governors, I'm sure between Joe and I, we can put something together. Is that okay, Joe? Thanks. Okay. Thank you, John. Anybody else got in? Oh, Rebecca. Sorry, Andy, it's your meeting. I'm just so.
Sorry, Sue. I was just thinking about this away time, and I know time is absolutely precious for everyone. As all the governors that were elected and present last year know, I did some research into leadership, and I'd have to work with the trust first to work out obviously what how to feedback and take it forward, but I'm very happy to put something like that into that away time as well. I'm very grateful for all the governors that gave their time for that piece of research. It was really, really helpful. Thank you.
Thank you for that, Rebecca.
Are there any other questions for Sue? I'm just thinking about that away day. Yeah, cyber security, very important, without a doubt. It's one of those ones we had for our Ned and exec away day. I was really surprised just how, I was going to say gripping, but it really was a very, very good presentation. Clearly, there's a strategy development to talk about, and how far we're progressing along those issues, and I think that would be very helpful to get updates on that. I almost hesitate to say ICS because there are lots of presentations on it. Sometimes it's a repetition of what we had before, but perhaps we need just to think about the developments within the ICS as we get nearer the go live date. There'll be lots of different things happening. I don't want to just have the same thing we've had before, but it might well be as we get nearer that start time, there's more concrete matters to come up with. Because no doubt there'll be involvement for governors in the plethora of meetings which are bound to arise from the ICS. And there's been a lot of consultation with us about what the ICP, the partnership, will actually do, as well as the board itself, which is an interesting one, I think. So there's a number of things I think for us to think about. Just want to repeat my thanks to the governors. And what I should have announced, of course, while Joe was out of the room, has now come back, if I may at this stage, is congratulations, Joe, for your reappointment for another 3 years. And thank you so much for everything you do. You know, and a unanimous verdict from the Council of Governors to appoint you for another 3. So thank you for everything you do, and thank you for the Council of Governors on that decision. So if we could just make sure we record that one properly. Thanks very much. If there's nothing else for Sue, we move into item 7, financial operational plans. That's just you and Azra, I think. Joe.
Yes, it is. And I was just going to start with a sort of a few areas of context, I guess, in terms of the environment we're in before Azra gets into the numbers. So, I mean, as everyone knows, with the pandemic, there's been a special regime for funding of trusts for the last 2 years, really, which, with everything else we've had to focus on, has at least made it easier to manage the money side of things. That regime at the moment is coming to an end, albeit, as we've discussed, it's very difficult to say that COVID is behind us. I think we know there's going to be some continuation of the effects of that. But we're transitioning back to a more normal environment with the requirement that comes with that of having to make efficiency savings and such like. Add to that, we've got again, we've already touched on it at this meeting, the context of the statutory changes, the implementation of the ICSs, which are kind of there but not there at the moment, due to go live from July, and looking at financial performance, all aspects of performance, but particularly in this context, financial performance, both at a trust level but also at an ICS level. And we know ourselves that there are some financially challenged trusts within our area as well. So quite a difficult environment at the moment. The numbers are still moving around, but it's in that environment that ASRA is working incredibly well to try and set the numbers for our trust, for our financial and operating plan for next year. So I just wanted to sort of talk about that context. So ASRA, over to you.
It's at moments like this we wonder if Azra is with us.
I don't think she's here.
Right.
Oh, who's putting up the slides? Is that Azra putting the slides up?
No, Joe's putting up the slides.
Joe's running it. I'll get in touch with her.
So we've got slides put up, which I can't quite see. I don't want to jump this one on you, Joe, but are you able to take us through these?
As for a quick call.
Yeah, I think I could have an attempt, but I'm sure, and the plan definitely was for Azra to be here. I can say that. So if all else fails, I can have a go, but I think it would be better coming from Azra.
Well, if we then push this one back, see if we can locate Azra on this one. If that's okay, Joe, we'll come back to this item. Right, we'll move on then to the Oxley's strategy. Big priority number 3, making Oxley's a great place to Rachel and Nina, please. Who's going to talk on this one?
Andy, I'm happy to make a couple of comments for a backdrop, which I think is important to understanding the kind of bigger picture. And I'm sure I'm not going to say anything that we're not all already aware of, but I think in terms of the work, and you'll have seen from Rachel's paper quite how much work is underway and the number of strands that are involved in pulling together this part of our strategy. A big emphasis has to rightly be on acknowledging the need to rebuild where staff are at and the journey that people have been on over the last couple of years. And I think we've said it before, but it's worth just reminding ourselves that the impact of the U-turn on VCOD was a lot more significant than I think any of us will necessarily understand or appreciate, certainly at an emotional level. So I think while I'm confident that staff are doing everything they can and should to look forward, I'm glad and I'm grateful to Rachel for all of the work that's underway, and to Iffy and the entire exec team for all of the work that's underway to do that rebuilding that I think really is key. One of my biggest concerns moving forward over the next year is our ability to turn levers that I think are going to be quite important for staff at all levels of the organisation, but particularly those on the front line and a number of specialties. We are in a quite unique macro environment. We have inflation running higher than it has for a very long time. We're seeing price rises in energy prices, in a whole load of other things, and it's not just Ukraine related. This has been on the cards for quite some time, and there's no way that any pay rise for staff at any level is going to match that. So I think we need to be really mindful of the squeeze that staff are going to feel, and think as mindfully as we can about how we can support them with some of the wellbeing initiatives that we have in mind. So those were the two comments I was going to make in terms of backdrop, and then I think it's Rachel taking us through the detail of the paper.
Rachel?
Rachel is having some trouble joining, so I'm just going to see if I can help her resolve that. My apologies.
Okay.
Andy, I'm very happy to take questions on I don't think there's any merit for anyone to hear from me on what's already in Rachel's paper, but if it helps while she connects, I'm very happy to take questions. We did have People Committee yesterday, and we covered a very large number of areas, and we had Sue with us from the governors. So I'm very happy to answer questions if that helps bridge a gap.
Yes, certainly. We don't want to just pad it out unnecessarily. But talking about People Committee, obviously one of the issues which you already touched on is recruitment and retention. And quite clearly, everybody is in the same boat. So it's almost the question is, what ideas have we got which are in any way new, or are there any other things we can borrow with pride from other trusts to recruit and to retain? Did that crop up at all, Nina?
And Saved by the Bell, it did, Andy, and it's been a focus of discussions in recent People Committees. So I'm sure Rachel can talk about the initiatives that we have both operationally in terms of doing as much as we can to recruit and retain in terms of our internal processes, but equally the strategic stuff with international recruitment, for example. So I'll hand over to her.
Thanks ever so much, and my sincere apologies for the delay. My mother's just been taken into hospital, so I'm really sorry. I thought I was on a little bit later, so my apologies. I'm so sorry to have missed the main body of it. In terms of recruitment and retention, it is our biggest focus at the moment. Nothing is more important for us than getting the right number of staffing so that we can deliver the quality care that we need to be providing as an organisation. We've always had a big focus on this as an organisation, but we've been doing even more over the last 3 to 6 months. We now have dedicated recruitment hotspot roles within HR who work directly with our service directors to tackle those areas where we have the biggest problem in terms of recruitment. We're exploring international recruitments, although that's not straightforward, but to see if that provides alternatives for us. We are thinking very carefully about the branding that we do to make sure that people understand why they should come and work for Oxley's. And there are a number of good reasons in terms of how we approach our bank, in terms of the focus that we have on well-being, a whole host of things that try and make this better. We are looking at graduate schemes to be making sure that we take advantage of that huge number of people coming through from universities who really want to work in this sector. We're also looking at how we can explore different type of roles that make sure that we use those skills that our registered nurses have and others, those really hard to recruit to roles, that we really use them for where they can most add value. So there is a massive programme of work. We have a new workforce planning steering group that Ian is chairing and that we're all involved in. And we are working with each of the directorates to develop a plan for each area to tackle each of them. So I can't emphasise enough to you just how important this agenda is to us in Oxley's, because we know the impact that this has on patient care, on retention and the experiences of our staff. So it's something we take very seriously.
Thank you, Rachel, and thank you for the huge amount of effort that you're putting in. You personally are putting a great deal into this, I know, and your leadership in this has made a real difference. Are there any questions for Rachel or Nina at all on this? Suzanne, please.
I just wanted to make a comment actually, and as Rachel and Nina know, I've been participating in a programme for NEDs to help us to really ensure that we're implementing our diversity practices effectively, particularly around the workplace race equality strategy. And what I've learned from that is that whilst we still have some distance to go in really accomplishing what we want to, we are streets ahead of some of the other London trusts. And I wonder whether we really make the most of that in terms of our approach to recruitment and sort of offering a view that in many respects Oxley's is a good place to work for people from different ethnic backgrounds. And it may be that, you know, as I say, that we haven't got absolutely everything right and that sometimes the data that we get are disappointing, but at least we're putting our back into it and really endeavouring to make it work. And I think that matters a lot, actually, that we're making the effort and really committed to it, because that's where I think we do genuinely differ from some of the other London trusts, is that we're really committed to this agenda.
Thank you, Suzanne. That's really good to hear. Nina, please.
I think it was Stephen Dilworth, wasn't it? I saw Stephen's hand up.
I can't quite see. I've got a number of.
And then Rachel. I was just going to come in after Rachel, Andy.
If you just come in now while you've got the floor, thank you.
So I guess I was going to say thank you to Suzanne for that, and just to endorse that I think Oxley's is streets ahead in the work that's underway on BAFO and has been for quite some time. And I think for me the biggest difference is the amount of thought and care and engagement with staff. We hear from each of the staff networks when we have people committee, and I haven't seen any other organisation that has the level of engagement that we do and the level of dialogue that we do. So that for me is a really important channel that we're using. I think just to underscore some of the things that Rachel was saying about recruitment and retention and the challenges, one of the things that we're doing a deep dive into is trying to understand the reason, and actually we saw an enormous amount of information on it at People Committee yesterday, trying to understand the reason that people join us, and the 3 or 4 kind of key drivers and the reasons that they leave. And it's disheartening to see that we have about 750, 800 people leave us every year, and we have a similar number who join us. And the pace at which we have to run just to stand still is really quite astonishing. So I'm sure we're not alone in this, but I just wanted to illustrate for colleagues the scale of some of the challenges that are involved.
Thank you, Nina. Stephen, did you have your hand up?
Yeah, thanks, Andy. And just to echo what's just been said, I think certainly Rachel has shown immense leadership on this. It's a tremendously successful program. And I just wanted to mention, as part of that, supporting that, is the very active board visits program that we got for non-executive directors. Why I think it's of value, especially during the past couple of years where it's been so difficult, is it does give staff access to non-executive directors. Allows us to hear at first hand what their issues are and to get feedback. I'm trying to avoid using the word coalface, but at the very front of our activities. So we're very aware of what's happening. And I think there's kind of good and not so good news comes out of that, because obviously it makes us really appreciate the tough times that staff have been through, because we hear that constantly. But on the good news, what we hear constantly is how strong the spirit and morale is within teams. That self-supportive piece, it's phenomenal. We hear it constantly from staff saying, we're really stressed. We've really been stretched in our work with people being off, but within our team, we work tremendously well together. And I know it's something that Rachel's got in her mind, certainly something we've discussed before. There is that piece about our existing staff recruiting other staff from outside Oxley's. I think, that our existing staff have an enormous part to play here, because I think that they've got many opportunities to say what works so well within Oxley's. And I stress, of course, none of us are being naive. We're not. It's not a perfect organisation, and there are issues to address. But I think fundamentally, there's more good to say about our staff environment than bad things. But certainly, a huge amount of progress has been made, I think, on this service. Thank you.
Thanks very much, Stephen. Victor, please.
Rachel, thank you very much for the presentation. Actually, I have two questions to ask. The first one is, I'm just wondering if there is any consideration of having ongoing bank recruitment. Reason being that there are people within the local that may not be interested to come into full-time job, but because of family commitment, they will fit into that sort of flexible arrangement to work on that bank system. That's one. Then secondly, we the trust NHS Oxley's Foundation, we spend money training nurses, committed nurses that end up obtaining an AMP qualification. I'm just also wondering if they will have provision to absorb these individuals, because what happens is that when individuals, they've completed their training, they're being absorbed by other trusts. They leave and join other trusts. So I'm just wondering if we are looking into that as part of our recruitment arrangement to absorb all this trained experience AMP, so that we can distribute them among other clinical practice, and they will be there to support junior nurses. Thank you.
Yeah, thank you, Victor. Rachel, please.
They're both really good points, Victor. Thank you. So yes, we are constantly recruiting on bank. It's a constant effort for us. We do want to persuade as many of our bank staff as possible to join our substantive staff, because we think you get even more benefits when you're a permanent member of staff in Oxley's. But we also recognise that bank staff are fantastic at being able to provide that flexible resource that we need, and particularly with things like COVID, and often we have kind of peaks of sickness, being able to draw on a really brilliant trained group of bank staff to be able to plug some of those gaps is really vital to us being able to keep things going forward. We're also working really closely with local communities, with schools. I had a meeting with schools yesterday to try and work out about trying to get those pipelines all the way through the colleges and things into Oxley's, into our apprenticeships. We've got 130 apprentices at the moment. We are really creating those pipelines through the organisation so that we can bring in and link with local communities. So all of those things are really good ideas, Victor. Thank you. I also just wanted to mention that what the staff survey results will show when we can publish those is that we need to do even more on equalities. We need to do even more on well-being. We know that it's always going to be a pressure to recruit new people into the organisation. We're piloting some of the great ideas that Steve's been coming up with. But what's most important really is that we don't lose the brilliant staff that we've got at the moment. So also focusing on retention is really important too. And that equalities agenda is one that, you know, I think we're making good progress. We hear from the networks that they're really pleased about the direction of travel, but we are not all of the way there. We are in the foothills of a very, very large mountain, and we need to really double down if we're going to deliver the improvements that we want people to see on a day-to-day basis. So I don't want you to underestimate my commitment to this. I really, really want us to see these changes, both from a wellbeing perspective and from the quality perspective, because it all comes back to the quality of care that we need to be providing to our patients.
Thanks very much, Rachel. Very, very grateful for that. Are there any further questions on this topic? If not, we'll go back to finance with Azra, please. Thank you, Azra.
So apologies, I was in another meeting, so I hadn't been there at the beginning. Joe, have you done your briefing? I can see Andy nodding his head, so I think that's already happened. In which case, Joe, could you possibly, Joe Mant this is, could you possibly put up the slides? This is going to look like a lot of figures for those of you that are not accountants. But I'm going to do a little bit of a step through, and please feel free to ask any questions. I will try to keep it quite high level in terms of explanation, but you will be the ones to judge whether or not that makes sense. Okay, so given the briefing that we've got, apologies that the papers came out quite late, but the figures were still changing and just being finalised yesterday at the ICS Chief Exec meeting. And what I don't want to do is to present a set of figures that would alter. If I can just take you at the beginning part to the table of figures at the top. And what I'm going to try and do is just step you through the overarching position between the first column, which is the recurrent position for 21-22, where we would expect to be at the end of the year in budgetary terms. And recurrent, let me just explain a couple of terms to you. Recurrent means it's the year-on-year position we would expect to be. So that's the income that we would expect to receive every year and the expenditure we would expect to receive every year. Non-recurrent, which is the next item, is either income or expenditure that only or it changes every single year and there is no guarantee of the income coming through. So that's really those two main terms, and there's quite a bit of balancing that we need to do when we set the budgets to completely understand what is going to be regular flows of income and expenditure and what will be blips effectively in a given year. So moving on to the left-hand table at the bottom, which will just step you through that second column. There were a couple of non-recurrents. The first is on Kent Prisons. We've taken out the old Kent Prisons figure for that contract that ended, because you will see on the left-hand side of the next column along, we've replaced it with the new Kent prison contracts that we're going to receive in 2022-23. So we've effectively taken out 7.23 million being the old and replaced it with 21.4 million being the new, because we've got significantly more work that we're now doing in Kent with those new contracts coming online. The second element, and that happens on both income and expenditure for both what we've done in the non-recurrent column and what we're doing for the 22-23. We then had something that we call the cost improvement programme. Now, for the last couple of years, we've been in a completely different funding regime during the pandemic than we would normally be. And what we were given is very significant block amounts of funding. What that has allowed us to do is manage within our overarching income envelope, I'm going to say fairly easily over the course of the last couple of years, and that's going to fundamentally change next year. So what this happened is we had a set of SIP targets of about 3% we had to meet in that year, and we met those via vacancies or the fact that we weren't able to recruit into posts where we had new monies coming in for mental health investment standards, etc. This is not that we were holding back recruitment, it's that literally we were not able to find the people out there to be able to recruit to. Moving on to the table on the right-hand side, just on that, I've already gone through the Kent figures. The net tariff inflator is effectively the uplift that is given to all of our contracts by our commissioners, and that is usually, it should be covering things like pay awards, it should be covering things like inflation. They automatically feed in a 1.1% efficiency target into that particular element. We had new lots of investment in mental health, being the 4.5 million mental health investment standard. And what we're seeing now is a tailing off of the very significant increase of funding that we were given to see us through the pandemic. So they haven't taken all of it away, but they have reduced it substantially for 2022-23. And the two figures, the two elements of system top up and COVID-19 expenditure is about 6.3 million for next year. That was topping 11 million in 21-22, so it's a significant drop. On expenditure then, the key changes are the expenditure for the 2 new Kent contracts, pay awards, and we've assumed a 2% pay award. That's still got to be determined, so the pay review body will come back and tell us what the pay award for next year is, but we've just put a holding figure in there. And for those of you that have been keeping up with the news, the health and social care increase in national insurance has also then been factored through here, and that comes to £7.9 million. Interesting point to note there is that in the income, we talked about the net tariff inflator, i.e. what we're given for all of our increases in costs. You'll see that was 5.3 million. And from the figures that I've just quoted, that's 7.9 million. So we're already needing to make some additional savings in order to bridge that gap. We have assumed that whatever funding we get for our new mental health investment standards, we will spend, which is why those two £4.5 million figures are the same. And then we've set aside some generic pots for cost pressure, some non-pay inflation, and 1.4 million that we've currently put aside for energy costs. We don't actually know what those energy cost hikes are going to be for the trust. This is assuming a 54% increase in energy costs, but we're going to have to wait and see to when we come out of contract to see what that looks like. We have been told from the centre it is very unlikely we will be given additional funding for this. So we're going to have to manage that cost pressure as it arises in year. We've got something around pass-through costs for the provider collaborative, and that's for all of the subcontracts that we hold for the adult secure, where we are the prime provider. We've had for a number of years a discussion about the level of pay for the people that work for ISS, and they're our subcontract provider that does all of their cleaning, portering, those types of costs. These are individuals that have been on the lowest rate of pay effectively, and the current contract that we have with them is paying them the living wage, but not the London living wage. And I should just point out here, the London living wage is less than what a Band 2 gets. And we've said this year, bearing in mind some of the pressures that particularly those at the lower end of society will be with things like energy increases and the increasing level of inflation generally, that we would ensure that we were able to pay them the London living wage. That is going to incur a £600,000 cost pressure that we will have to now effectively find every year. The next item I'm going to say is a technical adjustment, because it would take me about 10 minutes to explain exactly what that change is. This is a technical adjustment just in accounting standards that unfortunately means that we have to find between 300,000 and 500,000 of additional monies to cover the increase in expenditure that we will have. The last item then is the clinical negligence scheme. So that's effectively the insurance policy for all of the work that we do from both a clinical point of view, but it also covers some of our things like people having trips and falls and those type of elements. and it's the insurance scheme that is set out for all NHS trusts and allows us to be able to buy into specialists that effectively provide that insurance. Can we move on to the next slide, please, Jill? This is effectively just reshaping exactly the same as the table that I've just taken you through. So I'm not going to take you through line by line, but I am going to now just concentrate on the 4 red figures that you can see within that column. Because what this does is it takes us from the £13.5 million problem we had on the previous slide to the break-even position, which is what we're hoping the plan for next year will look like. So the first element of that is the system and COVID top-up of 6.3 million, roughly. The thing to remember there is that is non-recurrent. That figure will reduce in 23-24 and will carry on, we think, reducing in future years. If that figure, through the negotiations that we have with South East London ICS, reduces, the pressure on the trust will increase and we will have to find that money from somewhere else within our envelope. So that's just one of the things to effectively keep in mind as we're looking at the plan for next year. We then thought through, what do we think the mitigation elements would be? What do we think we could try and do to make sure that we can bridge the gap to show a balanced plan? The first one of those is, we think even with the best will in the world and recruiting as hard as we possibly can, we will probably find that there's about £5 million worth of posts via some of the new money, via some of the existing posts that we've got or turnover in them, that we will have about a £5 million underspend across pay. And that would be our first non-recurrent mitigation. And the reason that we're saying that that's non-recurrent is we're still really aiming to fill all of those posts sometime in the future. The second was we took a decision, actually before we went into the pandemic, that we were going to take a top slice of any new monies, any new bids that we had, and have as a contribution to our overheads, which again helps us to bridge that gap. So we took all of the income that we'd received for the last 2 years and we top sliced it, and that gives you the second mitigation element of just a little bit over 2.6 million. That then leaves us with a £5.9 million gap, which is the bottom figure, and that gap, which equates to about 1.53% of our expenditure target, is then what we're actually asking all of the directorates to go out and try and find as efficiency savings. Hopefully those will be recurrent, but I think there will be still some of those that are non-recurrent. All of those mechanisms then will then allow us to deliver a kind of balanced plan for next year. Can I just have the next slide, Joe? Okay, on this one, what we were effectively showing, the figures when we go through the timeline in black are the ICS or national timelines. The figure, the narrative in red is the Oxley's governance that we've got working through these plans as we move from the draft plan, which is being submitted by the ICS today, to the final plan, which has to go in at the end of April. And I'm going to say the complexity that's now been added in to agreeing these plans while we're working within the ICS has meant that it's, I would say, a slower process than we used to have pre-pandemic, because back then we were able to plan, we knew exactly what our position was, we had certainty and we could plan for it. We're now in an environment where we're having to work within the South East London ICS, and our plans and our figures have got to take into account the overarching ICS position. So on the 3rd of March, the Oxley's board delegated final sign-off to the business committee. As I've said, we're already at the 17th, so we have submitted now our draft operational plan, and what you've just seen in terms of the table I took you through is what we put through for that plan. We will continue to now see iterations. The next one will be the Financial Sustainability Group, which is an executive group, and we're hoping to sign contracts by the 31st of March. I think we will definitely land there for the CCG contracts. there is a little bit of still additional movement and discussions to be had on our NHSE contracts. Jo, could I just have the final slide? Thank you. So in April, we will now work through the final iterations as we work through the draft to the final plan, and you can see exactly how that will then be progressed through the Oxley's governance and what we're hoping to effectively deliver for the 28th of April as the final plan. I just thought I'd end with the financial position of each of the South East London trusts as in what they submitted today. So what you're effectively seeing is the CCG and ourselves are the only organisations in South East London that submitted a break-even plan or a balanced plan. All of the other trusts submitted deficit plans, and the system as a whole, after some meetings with NHS England, the regional team, so it's the London regional team, we were asked to make some additional savings, and they have committed, I have to say, principally the acute trusts and a little bit from South London and the Maudsley, to collaboratively pull together £19 million of additional plans. There is no real detail, I would say, against that. And at that £102 million deficit, which is what the plan submission currently looks like, there is an expectation that between now and the end of the year, the ICS would be able to submit a balanced plan. So that was a lot of words from me, and I'm sure there will be questions on that. Jo, do you want to take it down so that we can fully see everybody and just check any questions on that? Jo, is there anything, Jo Stimson, as opposed to Jo Mad, is there anything you'd like to add to that coming out of the business committee?
No, as you say, Azra, I mean, the business committee is sort of fully up to speed with this. We met on Tuesday. The numbers have moved a little bit in terms of that overall submission since then. I think what your slides show is this is pretty complex. And as you say, it's trying to agree our position, not just in terms of us as a trust. And clearly we are responsible for our own position. We sign as a board and you know, up to our position, but also there is that much stronger context for the ICS than we've had in the past. And clearly the pressure is on the ICS from the centre to deliver a certain position. I think it's right at this point in time for us to hold our position on a break-even plan. I think I expressed on Tuesday that, you know, a break-even plan is very defendable position, but, you know, we must be aware of pressures coming through. And at the moment, as you can see, just to get to that sort of negotiated position with the centre, which currently is a £102 million deficit, there's a 19 million completely unallocated. And it's probably also worth saying that, you know, just like us, where we say, you know, we're not quite sure how we're going to get there. We need to generate savings. We don't have those already really well defined. Every trust on that sheet will be in exactly the same position. So, you know, it's not like there's a joint task of 19 million extra savings on top of something that is really well thought through. There's quite a lot of challenge there. So lots to do. You know, as I said in the preamble, our ICS is quite financially challenged, but it's fair to say London as a whole isn't in a great position, and you know, and then that goes out further as well. So very complex. And I would say I think Azra and the finance team are doing a great job on this. It is really, really tricky stuff. And I think what we take confidence from both at board and business committee is I think we have a team who really understand our numbers, who are very reluctant to spend money that we don't have. You know, I think that is a real strength.
Thanks very much, Jo. And I endorse Jo's thanks to you, Ezra, and your team on this, and for your explanation that I could follow all the way through. So I was really, really grateful for that. Well done. Thank you. Any questions for Ezra or Jo? If not, then thanks ever so much. That was really, really helpful. Challenging for everybody, as Jo said, but we shall see, and you'll be updated in due course as the year unfolds. We're going to have a short break now. If we come come back in 10 minutes. Well, let's make that 15, 30, 45, please, if that's okay with everybody. And Alison will come to you on Xcare when we come back, if that's okay. All right, we'll see you in about 10, 11 minutes. Thanks very much. back, everyone. If we can now move on to item 9, which is Alison, please. Over to you.
Thanks, Andy. So for those that don't know me, I'm Alison Furser. I'm the Director of Informatics, and I'm actually joined today by Laurel Morgan-Bruce, who's been Programme Managing the Oxcare project. And we're going to do a bit of a double act today with the Oxcare presentation. So Laurel, I'm hoping you'll be able to share the slides.
That's sharing with you?
No.
How's that?
Yep, perfect. Okay, can you go to the next slide? Okay. So, what is Oxcare? I'm just going to mute. Okay, so yeah, what is Oxcare? So Oxcare is our online health record that we've been designing and developing with a large range of staff and service users and carers over the last couple of years. We're really excited about the opportunities Oxcare could offer to engage our patients and their families and their carers with their care in the future. If you, I guess, reflect back and think about how many of us use technology in our everyday lives nowadays and the changes that we've seen, say, in the retail and the banking sector over the last couple of years, you can perhaps start to see the opportunities that a tool like Oxcare could offer us. I know, for example, I'm much more engaged with my finances now that I've got an app on my phone, and we think that providing our service users access to their records and some support tools online, we could really change the way that we work with many of our patients. So if you could just pop onto the next slide, Laurel. In terms of Oxcare itself, as you can see from the picture on this slide, we've had really good involvement from quite a broad range of stakeholders from the very start of the project. And what you see on the slide is an early requirements gathering exercise that we actually held in person prior to the pandemic hitting. And we stipulated some key design principles at the start of the project. We wanted to make Oxcare something that was easy to use. We wanted to make sure that it was easy for patients to share information with others involved in their care if they decided that they wanted to do that. We also wanted to ensure that we could share key information such as care plans and letters so that patients have got easy access to that critical information all the time, assuming they've got access to the internet. Next slide, please, Laurel.
So, oh, that didn't click over for some reason. That just submit me. So, there are 4 sections to Oxcare, and these are just some screenshots that we've taken off the latest version of it. And you'll see there's 4 sections under Oxcare: care, community, trackers, tools. And over the next couple of slides, I'll give you a bit more detail about them. So under the care banner, we've got things such as About Me, which is information the service user can enter, and I've just given you the headings there, so I won't go through them. The appointment, so a service user can see what appointments they have, they can see where it is and what time it is. Under My Health, they've got the ability to see their care plans, their crisis plans, and add notes to them. And then My Documents is basically talking about the documents that we send out to the service users, which they can access at a time that suits them. And then Questionnaires is the fact that clinicians can send service users questionnaires either before their appointment or after their appointment and have them completed before they come in for a session. The next one I want to talk about is the community, and this is where service users can invite family and friends to join them to have access to certain things within the system, and the service user decides how much information they're willing to share with individuals. It could be also, the other thing we ask them to do is to invite their care team with them. So the care team can have access to certain information as well that the service user puts in. Messages between anybody in the community are also done here, and we have been very clear to stipulate that if it's a crisis, they're not to use this system.
And if they do contact the care team's got 3 working days to respond, and that was the timeline that was decided by the service users involved in the project. The third section is the trackers, and here individuals can keep a record of their pain, mood, sleep, alcohol, and then use a dashboard to overlay whatever the trackers they're using to see if there's anything that triggers them during the day, or particularly notice if something their drinking's up or down, or their mood's up and down, as they can see that. The fourth one is the tools, and here we have a number of different things. We have some NHS approved ones, and then we have the trust resources section. And under the trust resources section, we have things such as videos for the MSK service users to give them exercises. And then we've also got things such as leaflets that we hand to service users that they can look at a time that suits them, some tips and helps. And we've also in the process of looking for local events that might suit service users or their carers. And we can put these in here so that they're also available for the service users. Over to you, Alison.
So really we see Oxcare really as a great opportunity to enable our patients really to have more control and greater voice in their care. One of the, as Laurel mentioned earlier, one of the key features that our service users told us they'd like to have is the ability to comment on their care plans, and so we've incorporated that functionality into Oxcare. And other tools that Laurel mentioned, like the resource library, will help clinicians provide more tailored care and advice to their patients. So again, as Laurel mentioned, you know, MSK patients might have videos of their exercises uploaded into Oxcare, and others might use some of the tracking tools to monitor their sleep or their alcohol consumption, which they can then discuss with their clinicians. Next slide, Laurel, please. So really what we hope is that by giving patients access to all that information in Oxcare, they're going to take a more active role in the ownership of their care and their records, because it's really easy for them to do so. We also want to work with our clinicians to get them to think differently about how we provide care using Oxcare. So, for example, if we can ask patients, as Laurel mentioned, to fill in questionnaires and provide updates on their care between appointments, we can perhaps spend more focused time on their achievements and their goals when we meet with them, rather than spending the whole time information gathering. And that could mean that we change the duration of our clinic sessions, or perhaps use the time to provide more frequent, shorter appointments to support patients' care. And we were hoping that we should be able to tailor more to individual needs. But ultimately, what we're hoping is that we're able to provide more time for clinicians to care through the use of Oxcare. So next, what we're hoping to do, if Laurel can play the video, is we've got quite a few videos that service users and staff have recorded about their experience of being involved in the Oxcare project. So what we want to do is just play a short video that describes John and his reflections about being involved in the development of Oxcare, and also the reflections of Jonathan West, who's one of the clinicians who's been involved from the start, and how he envisages Oxcare being used in practice. So it's about 4 minutes long, but I'm hoping Laurel's going to be able to play that now.
I'm John Preston. I joined the Oxcare project as part of ResearchNet Bromley. I am a service user and have been a service user on and off over many years. So I felt quite honoured, actually, not only to be recommended to ResearchNet, but then to be recommended to the project. When I spoke, I felt listened to. I was listened to. So that meant something to me. And there were other service users involved as well who were articulate, and they were listened to as well. So quite quickly, I felt that this was a co-production. I think that the care plan's really good as well. It as a service user, it makes me feel like I've got a little bit more control over the information that's held on me because I've inputted it. And that's important when you struggle with poor mental health, to feel like you've got some control. And I do think that Oxcare offers that possibility. At the age of 56, I've come across a new piece of kit, a new piece of tech that I'm not afraid of, and that might well be able to help support me as a service user when I need it. It gives some meaning to the position that we find ourselves in as service users, which is people that struggle with poor mental health, because that then becomes one of our areas of expertise, and it's one of our areas that people around the table really want. They want to know what someone who's in crisis or struggles with poor mental health, how that person's going to react to the app or to different aspects of the app, I mean, if you're given the opportunity to co-produce, if you're invited aboard, then I would say give it a go. You'll be being invited aboard because whoever's running it thinks that you have what they need to make the project more successful. So you will be valued if you're a service user. I can't speak for the professionals, but if you're a service user and you're invited aboard, then take it as a compliment in the sense that you have skills that they need. But be reassured that if it's like my experience, you will be heard, and you will be being invited aboard because they will want your contribution.
They'll be able to go in and rate things like their mood, how well they've slept, have they been drinking any alcohol, how they've been feeling. And then they themselves will be able to track and monitor how things are going. And then when they next see their Oxley's clinician, it gives a really good starting point for both of them to have a dialogue, to look back and say, okay, look, you've been saying your mood has been low over the past week. What's been happening? Why is there a reason for that? Or your drinking went up at the weekend. What was the reason for that? So I think the tracker section is a really fantastic tool that will benefit service users and Oxley's clinicians. I think sometimes it might be hard for patients when they're sitting with us in Oxley's, with a doctor, with a nurse, with a psychologist. It can sometimes perhaps feel a little bit overwhelming, and maybe you don't ask the questions that you want to. Maybe it feels silly or inappropriate to make those comments. But hopefully when you go home and you look at your care plan and you look at the things that have been written and what the goals and the aims are, you can reflect and say, well, actually, I don't completely agree with that. And I've actually got something to add to that. We're actually getting sort of more value for that consultation. So we might be having a half an hour face-to-face consultation, but within that meeting, we've got the richness of maybe a month's worth of trackers and comments and all sorts of other things that can then be brought into that meeting. And I just hope that clinicians get behind this project because it is very exciting. And I think the more staff use it, get comfortable with it, I think a year down the line, we'll look back and we won't be able to remember a time before we had OxCare.
Okay, so there's more detail on that video on the Ox, and I think we're also planning to put it on the external website for people to look at. So we've got a number of really exciting things coming up in the summer. Proxy Access, which means that service users or parents who have more than one child will be able to go in and access all three of those children with one email address, because it is limited to one email address, OxCare. So that's a really exciting thing to be coming. And then thinking forward, we want to be able to allow service users to reschedule, change or cancel their appointments, which will just make their life a lot easier, and do it at a time that suits them as well. And then we've got our rollout plans. These have been agreed across the trust. We have a 8-week onboarding process. And while this seems like a long time, we need to ensure that teams are ready. So we're working with them and we continue to tweak the process to make sure we make it as robust as possible. We will be evaluating the system and we'll be using patient surveys, looking at the data that we have, because service users will be able to update their demographics within Oxcare. So we'll be looking at a number of ways of ensuring that Oxcare is performing and allowing us to reach the benefits that we expect to see. This is a rollout plan, and as you can see, it's quite a busy rollout plan. This will be going on the external Oxley's NHS Foundation Trust website so that service users can see when their teams are due to go live on the system. And we're conscious that there's service users out here who don't have either the skills, internet access or devices. So we've been learning from other organisations on what they've been doing. And then we're going to start to investigate things that we as a trust can do, including working more closely with the local care partnership in Bexley and looking at possibly repurposing older trust equipment that we can donate. So any questions?
Laurel and Alison, thank you very much. I think this is brilliant. I think this is really, really good. Thank you so much for that presentation. John, please.
Thanks. You made note in the presentation about it links with Rio. Does it work vice versa? So if I put somebody on Oxcare, is it going to pick up in Rio?
Not right at this minute, John.
Okay.
That is I have requested funding to do that. Initially, when we started, both sides, but we're unclear about whether they wanted it to automatically write back to Rio. But we have, since we've been working more closely with teams, and that's been one of their requests. So it's definitely something we're looking at. And it is a capability that's already, to an extent, been built into the system.
Because I mean, the obvious question going forward, isn't it? But then staff are having to look at two platforms, and I guess there's a multitude of platforms arising within health and social care, and I think it's trying to minimise. I can see the passwords floating all over people's head, thinking which one do I use for what, isn't it really?
Yeah, and that's one of the reasons we're looking at. We're also looking at single sign-on, so clinicians will only have one sign-on, which is their normal standard sign-on.
Okay, thanks, Laura. Yeah.
There's another one. Is that Ravimba?
Hello. Yes, thank you. This sounds like a really great initiative, and I'm really so happy that Dr. West has taken this forward and is championing it. And I really hope, as he said, that other clinicians will have the confidence to go forward with it as well. My question is, I wonder what is needed from the board to ensure that the introduction of Oxcare doesn't result in capable service users being excluded from Oxley's because they have successfully demonstrated that they can use Oxcare. So I guess my question is, what protective measures are going to be taken so that people don't end up being excluded? I don't know if that's clear at all.
I think from what, Alison, did you want to answer that one?
Go ahead, Ro.
I was just going to say, it's the bit about us working closely with third sectors to ensure people they're able to, or have a place where they can build up their digital skills. It's us looking to see where we can put or send people where they can have access to internet if they don't have it, e.g. some of the libraries, most of the libraries in it, but we are finding other places where we can also help direct them. It's us looking at what we can do with our old equipment that we're de-scoping, and how can we work with individuals to use that. And there's also something else that I've talked about or thought about, and I've discussed with Alison, is about looking about having pods around, which is just like a room within one of our buildings where service users can go and use equipment. So there is a number of things we're trying to look at to help that.
I think that's incredible, Laurel, and I think it's really good you're protecting sort of the resource side of things, in access with that. And I guess I'm also just asking. My experience has been that discharge is usually considered if somebody is competent and independent. And actually this tool is relying on competence and independence to some extent. So I would like to know what the board can do to help protect Oxcare so that service users are not failing to get access to Oxleys and are not being moved out of Oxleys too quickly because they have the capability for using this tool. So just some consistency throughout the trust in understanding that a capable person with mental health issues doesn't mean that they don't need secondary mental health care.
I mean, I would say we're looking to Oxcare being something that complements services, not is instead of services. So I would hope that that's how we use it across the entire trust.
Absolutely, and I think that's what it's doing, and I think it's incredible. Yeah.
Thank you.
So I think the question really is how can the board make sure that it tracks maybe how people are being progressed through Oxleys because they can use this tool. So I would like to, I'd love to see in the future that people are being progressed through Oxleys by using this tool, and the expected outcome of, you know, independence and coping and living well is what's happening, rather than perhaps and looking at where occurrences are happening where people are actually starting to not have access because of their competence, and sort of dealing with that old way of engaging with service users of, well, if they're competent, then they don't need us. Yeah, so just sort of like plugging out the old way of engaging with service users where there's resistance maybe, or lack of understanding.
I mean, we will be doing.
Ian wants to come in. I think Ian wants to come in as Director of Operations. Ian.
Hi there. Hi, everyone. I'm Ian Diamond. I'm the Chief Operating Officer. I think it's a really interesting question and a really fundamental one. And I think it's interesting it's come up in the context of Oxcare. I think even if we didn't have Oxcare, it's a live conversation, isn't it? And how we might see somebody's recovery journey as being a positive thing, it might generate a lot of anxiety for the service user about the loss of connection with services that support them in their independence. So I think it's really about recovery being a kind of joined up process and a conversation that takes place. And, you know, certainly as a service provider, we need to be checking out with service users that they are happy with the direction of things, and making sure that independence, as you've described it, and perhaps less reliance on secondary care is a desirable outcome. And when people, and if they do leave secondary care, how we kind of design a system whereby they can come back quite easily if their situation changes, because I think that's what people get fearful about, isn't it? That they feel fine now, but there may be a stage in the future where they need a bit more support, and that's really at the heart of some of our transformation work that's going on in each of our boroughs. So very happy to have a conversation with you outside of the meeting, and to get your views on this would be really interesting.
Thank you. And just to clarify, it's not a criticism, it's actually a sort of, I'm really excited about it. Thank you.
Oh no, I didn't take it as a criticism. Well, I'm sure none of us took it as a criticism. Yeah.
Thank you.
Thanks very much. Yvonne, please.
Yeah, I was kind of following on from the question about links between this and your operational system. I mean, we have a scenario, if I've understood correctly, where service users may be inputting their experiences and patterns of activity, like you said, to drinking a bit more or whatever it might be. Does anybody proactively monitor any of this? Because in kind of theory, on an Oxley's platform, there might be information which indicates that someone is going into crisis. And if we've not got any triggers in it that kind of send up a red flag, if they start inputting things that if they told us face to face would send up a red flag, could we be seen to have been negligent in some way? Which is coming back to the link with Rio. So, you know, if it were in an operational system, the chance of it being picked up are probably much higher than if it's just sitting on this customer system, if you want to call it that. Do I make sense?
Yeah, you do. That's really interesting, actually. Alison, can you answer that, please?
Yeah, I mean, I think it's a really interesting question. We obviously don't currently monitor a lot of this information around, you know, drinking or tracking moods, etc. So it's something that we're going to be doing for the first time, and we're very clear at the outset with our patients about how we're going to be monitoring that information. And we have James Willard, who is our clinical safety officer, who's been taking a look at the functionality within the system and the safeguards that are in place. So I think from, as I said, we're very clear with the patients that we won't be looking at that information on a real-time basis, and that will be used in clinic to support the conversation. You know, if they go into crisis, they would contact us in the normal way that they do today.
Yeah, I mean, I think it's something for you to ponder on, whether there is anything in the data that they might be entering which could constitute a real red flag warning, and how that might be a level of sophistication that goes into the system at some point in the future. Because what we're basically saying is we're using that information passively, i.e. when we sit down in front of them, we'll have a look. But there, you know, there could conceivably be a wealth of stuff in there, and there might be situations where we could avoid a crisis. I don't know without, you know, kind of getting into it, but I do think it is something to think about. I also think about the link with the operational system. Once a service user has told us something, whether it be on this platform or face-to-face or by any other route, they consider that they have told us that information. And consequently, if they then move into a different phase of support and this information is not immediately available to the people who might then become involved in their care, they'll go, but we told you all this. So somehow we have to keep the information about the service user in its entirety intact, rather than having it scattered in multiple places, is kind of what I'm saying, I think. Or they're going to lose face. They'll say, I've told you, but you're now ignoring what I've told you.
I don't know if Ife or Laurel wanted to come in.
Andy, can I come in? So I think you make some really valid points there, Yvonne. But I would worry if some of those things prevent us from moving forward with regard to technology. So Alison and I were in a conversation earlier that pre the pandemic, you couldn't get clinicians to do virtual consultations. But now it's the norm, particularly in our IAP services, partly because everyone has now come to accept that there are risks, but broadly speaking, it is safe. So we are quite clear about how this platform should be used. It's for service users to lodge things, to access their information so that when they come into a consultation, the evidence is there and they can talk about it. It's not for them to put information that they expect us to monitor. It really is not. And if they are in crisis, then they need to use the routes that are available for crisis management. Now, if our clinicians begin to worry that suddenly the expectation is for them to monitor this stuff, then it's not going to go anywhere. And
No,
this is
I wasn't going to suggest it was
Yeah,
a manual process, but you can put triggers into data that if certain data is input, it raises a flag somewhere. And that would be an entirely automated thing.
Yeah, so
That's what
it may
had
be
in mind.
it may be that in years to come we can apply some of the technology to do with big data that helps us to trawl through and do all of that. But what we're currently discussing is the ability of users of our services to have in their hands access to their health records, and also to provide us information that can then help us working with them to find solutions that will be of benefit.
That was very helpful. Thanks ever so much. Suzanne, please.
I'd wanted to go back to Ruvimbo's comments, because I think it raised for me a very interesting question about how we would evaluate the way in which Oxcare comes to be used. And Alison or Laurel might want to say a bit about what kind of evaluation we're going to do. I'm of that generation who, when I was first introduced to email, said to my friend, God, I can't think who's going to use that. And everything that I've learned about technologies and sort of new approaches is that it can be quite unpredictable about how useful they become, or equally how quickly they fall by the wayside. The thing that I'm really hopeful for with Oxcare is that it would help with something which I think we recognise as a real issue, is really engaging the people around a service user in supporting them. And I think that part of Oxcare where the service user can choose who they want to share information with and enable those people to have access to information, which at the moment they probably would find it quite hard to access, I think is really, really valuable. And it'll be very interesting to see whether in use this does turn out to be a way in which that community of people whose care is as important, if not more important almost, as the care that we provide, can make a difference.
Thank you very much. We'll come back for any answers on that on Alison and Laurel at the end. So if we can now go to Stephen, please.
Thanks, Andy. I think this is a great conversation, actually. First of all, I think the initiative is absolutely brilliant. You know, it's exactly what we should be doing. And I'm mindful of that book, I think Radical Help, isn't it? Where about allowing patients to flourish. And I think this is exactly what this is doing, allowing our service users to become more engaged in their own treatment. It has enormous benefits, and as Alison touched on if you look at just something like do not attends, which in a physical environment, if someone doesn't attend an appointment, you know, the consultant has basically lost an hour, and so anything that sort of works around that is very, very useful. So I think it's a great idea, and I think Yvonne has raised a really good point here. And I think in the short term, it's about our communications, and if he's touched on this, that we need to make sure that service users are aware of the benefits of this system, but what it doesn't do. You know, this if you're in urgent crisis, don't use it to signal to us you're in urgent crisis. Go to your normal route. Where we need to be conscious and developing things for the future is in the longer term, and as if he says through big data, artificial intelligence, there'll be a more automatic means of monitoring this, which will deal with the issue that Yvonne raises. And the way technology is advancing, I would think that won't be too long off. You know, I don't know, 3 years, something like that. But what's good about having points like this, it's exactly the sort of thing we should be looking at, because I think like all of us, there's a danger we can get caught up in what service users need and want now, 2022, but we've also got to be mindful of what will life be like in 2025, 2026? What will technology be enabling us to do at that time? And I think on some, this will grow and grow, and it will develop more. And at that point about being able to monitor it more regularly, in time will come, but not just at the moment. But great idea. Allow patients to flourish.
Yeah, thanks very much, Stephen. Yemisi, please.
Thanks, Andy. I think my point kind of leads on from what Steve Dilworth has said, and I think Oxcare is a fabulous system, but as Steve said, what's really important is how we communicate exactly what it does at the moment to service users. Because in my mind, what Oxcare allows us to do is actually improve the quality of consultation time between the professionals and the service user. Because how many of us have been in a consultation for 15, 20 minutes is all you have, and you can't remember everything that you wanted to say because, time's going, and you leave and you think, actually, I should have mentioned this, which would have added a richness to that discussion. So what Oxcare allows patients to do is to document that information without the time pressure of that 15 minutes. So they've got it there. So that when they go into that consultation, they're able to talk about everything that's happened over a time period. So I've seen it being done in other healthcare settings, and it's worked incredibly well. I think another aspect of it is the adjunct where it allows friends and family to be able to communicate with an individual and see what's going on with that individual. Again, I've seen it work incredibly well in social care, where friends and family are not in the immediate vicinity, but using a system like this, they can see what's going on with their loved ones and their family members. So again, it improves that support network that they have. It improves the communication within that support network, which ultimately creates, improves the holistic approach to patients getting better. So I think at the moment, that's how we've got to get it across to patients. And then the other aspects that we're talking about, we can then build on as we go forward. Thanks.
Yeah, thanks, Yemisi. John, please.
Thanks, Andy. I tell you, it's reminded me of, there was an NHS conference a few years ago, and the group of practitioners came from Chicago. And I wonder if anyone went to that, but it was then referred to as the Chicago model. And to me, it's clearly linking to what we're now suggesting with Oxcare, which I think is a fabulous idea. But clearly, they've had many years of experience. And I remember one of the practitioners talking about what they had to resist in the implementation was to start segregating people who couldn't use their care planning with family and friends and people who did. So, one of the opening questions when the client came in was, oh, have you gone on to Oxcare and used it? And said, no. And it sort of became a question. And in order to try and build on it, they had to employ care navigators who were, I think usually people who would use services, but they were facilitators who could then work with families and clients over a period of time to enable them to put into the Oxcare what was relevant to their care. So it's just a thought for, I guess, Alison, and just thought whether it's still around is the Chicago model as a reference point, really.
Thank you, John. Alison, to wrap us up, please.
Yeah, just a couple of thoughts. I mean, certainly around the triggers, the relevant team are thinking about, in terms of the developments that are going to come in the summer, there is some kind of simple word alerts that are going to be built into the system. So that work is in its infancy and will need to be built up over time. And secondly, just thinking about the benefits. I mean, we've listed some of the valuation criteria that we're thinking about in the presentation, and we think, you know, the benefits will be quantitative and qualitative. So, you know, patient surveys, you know, understanding from the carers who've had access to records, the benefits that they've seen from having access to the system, you know, simple things about how many patients are actually accessing their care plan, which is available online. We know that, you know, patients actually seeing and being involved in their care plan is a key activity that we'd like to promote in mental health. So being able to define that should be would be really key. And there's some quantitative benefits. So, you know, as patients sign up to Oxcare, they agree that their letters will be made available online. So we won't have the incremental or the costs of sending out letters to them in the post in the future. So there's some monetary benefits as well. But primarily what we want to focus in was obviously the benefits to patients and the improvements and the help that we can provide with their care. So I think that's probably all I wanted to say. Thanks.
Thanks very much, Alison, and thanks to you and Laurel. I think there's a great conversation, some really, really good points from people, but I'm going to come back to, I think this is a brilliant piece of work. You know, all the things that extra got to be done. I think this is a great innovation. So thanks to all of you and your team for everything you've done there. And we now move on to item 10, which is membership committee updates. Sue, please. Sue, have we got you?
What, item 10? Sorry.
Yes, please.
Oh, hang on, I've lost my plot on this one. What can you remind me what that was? I've done my report, I've done my lead governor's report.
Yeah, it's got membership committee updates. I think it's
sorry, apologies. Yes, sorry, leave me alone. One of those afternoons, too many things going on. Yes, just to bring you up to date, I did mention it at the informal governors meeting, is that some of you may be aware that Simon, who was chair of the membership committee, has resigned from that role. So we still want the membership committee to carry on, which is important. The last meeting we should have had didn't happen, but we have actually organised another one for the 23rd of March, if I remember correctly. I put an appeal out at the informal governors meeting that would people like to consider taking on that membership chair role, please. I'm going, as the vice chair, I'm going to chair the next meeting that's planned, but would look to somebody else taking it on, because as lead governor, I don't think it's appropriate I do that as well, and I do like to try and spread the workload. The membership committee is an important aspect of what we do. We are looking to do lots of things over the coming year. Joe Mant has been extremely helpful and put something together for the membership committee in March about what and how the membership committee is involved, and the trying to carry on with the work streams that we've got, and we definitely want to carry on the work. The people that we have involved in the various committees, we did raise that at the earlier informal meeting, and we're looking for, obviously, to people to carry on the jobs that they do and to keep the membership going, because I think it's really important that it's the membership members who make up Oxley's Trust, and it's important that we keep them involved. And I think certainly as a lead governor, I'd like to see people involved in that and to have some support in making sure the members group and committee carries on. And we're doing, there's quite a lot coming up over the coming year, hopefully, when as we come out of COVID, that we'll have an opportunity to do. A lot will still be virtual, I think, but there are opportunities to do things, and certainly when we have the next members committee meeting, we'll be able to explain more then, I think. But so sorry about that last minute gap from me. I was just trying to cope with something else from the family. Families seem to be the thing at the moment, don't they? It's all sorts of issues, but onwards and upwards for the membership committee, and I think it's important, that important work that they do, and hopefully we can find somebody who'll be willing to take over from Simon as the chair. And I think the thing that came up was one of the questions when was that there have been some delays in getting some of the work done, but obviously the young people's, we're looking at having a young people's group, that's been deferred until later on in the year when they next go back to college, because it seems that we need to get in line with their work stream as well. So it's working how we go forward that. So it's not been cancelled, it's just moving forward and taking it forward so that we will get some sort of young people's involvement, and that's important, trying to get that work through. And carrying on, Nikki, who does a lot of work for us with the young with prisoners, we look forward to keeping that going as well. So it's really just onwards and upwards for the whole thing. And the last year or so, 2 years, 18 months has been an interesting time for everyone. But as we've already said, looking at the survey that come out about meetings as how we carry on with that and make sure that it carries on, because I think it's a very important aspect of work. So unless anyone's got any other questions.
Thanks, Sue. Any questions for Sue at all? If not, thanks ever so much for what you're doing there. We move on to the next one, which is Trust Constitution. Sally, please.
Thank you. So every so often we have a look at our constitution and the makeup of the Council of Governors, just to make sure that it's fit for purpose and it's as effective as it can be. And I just thought it was worth having another look, because particularly because of the changes to the service directorates, and then how the staff governors represent those directorates. So I think there's pluses and minuses for the existing system we've got, and for aligning our council of governors to our service directorates as they've now been set up. But what I would like to do is just put together a small group to have a look through how the makeup of particularly the staff governors is, and make any suggestions for changes that we can bring back to the council of governors. So I'm asking for people to volunteer to meet with Joe and I virtually and talk through some of the issues and get some opinions. So please could you get in touch with through Anne-Marie if you're interested in taking part of that. It'll be a short piece of work, just having some discussions. I'm happy to take any questions.
Thank you, Sally. Any questions for Sally? So volunteers to Anne-Marie, is that right, Sally? Okay, we'll look forward to a flood of volunteers coming in on that one. Thanks ever so much for that. If we move on now to item 12, Quality Management Framework, update on the selection of a local indicator for external audit. The MSC and Abby's names against this one. Who's going to lead us on this one, please?
I'll lead and then I'll pass on to Abby, if that's okay, Andy.
Thank you.
Thank you. So we discussed at the last meeting about the selection of the local quality indicators. But since then, there has been further guidance that's been released, and we just wanted you to talk you through what that guidance is. And before I pass on to Abby, I just wanted to again just give a quick update as to the work that the quality Performance and Quality Assurance Committee have been doing over the last couple of months, and just let the governors know that we've have oversight over the new directorate structures, and they've been coming to give presentations to the committee, and that's been really useful in ensuring the governance that they've got within their directorates, and how they're using standardized approaches with services across the different boroughs, and effective use of resources and redistribution of that resources, and trying to find innovative approaches to the challenges that we all know that we have in the NHS, such as waiting lists. But I'm going to pass over to Abby now, and Abby can give us a further update on the local quality indicators. Thanks, Abby.
Thank you very much, Yemisi, and good afternoon, everyone. I just wanted to say that following the meeting in December, there was national guidance issued by Sir David Sloman, who's the Chief Operating Officer of the NHS England. And Sue has put this in the lead governor up-to-date that she sent out in January. But it's just to say that the NHS England has removed the requirements for foundation trust to include quality reports in their annual reports. And this is the third year in a row that they're doing that. And as a result of that, we no longer have to choose a local indicator because we won't be doing quality reports as part of our annual reports for this year. So the discussion we had at the last meeting was around outcome measures as our local indicator, but we won't be carrying that forward. But one thing that did come out of the discussion last time was looking at care planning and looking at the time that's given to patients to determine their care plan meeting. So we've taken that forward, and that will be included in our care plan audit. So I don't know if anyone has any questions, but that's all I had to say on the local quality indicators.
Thank you, Abby. Any questions at all on that for Abby or Yemisi? If not, thanks very much. We then move on to external auditors contract. Stephen and Azra against that, please.
Thanks, Andy. As the governors will know, the appointment of external auditors is one of the most important roles for governors, and one certainly that's both appreciated and valued by the board of directors and staff. Our current external auditors are Grant Thornton. Their contract runs through to 2023, next year. So we need to start looking now at options available to us, which would include possibly renewing the existing contract or going out to the market to see what other competitors can provide. And we need to start that work now, really, because that all takes the time to make that decision as to which option we're going to go for. For what it's worth, I think I would say that Grant Thornton, who've now been with us for 4 years, they have been very good to work with. They've been very competitive on price, and they have come up with a lot of good operational observations, which we have followed through on. But nevertheless, it's one never relaxes about these things. It's always good to see what else is out there on the market, what other opportunities we've got. So at that point, and I'm now reluctant to mention the word volunteers, but because everyone's looking for them at the moment. But I'm now going to hand over to our Director of Finance, Azra, who's going to tell you a little bit more about what we want to do.
Thank you, Steve. So we've got a paper within, hopefully the paper is fairly self-explanatory that we put in within the pack. I think the key issue is when we're looking at this process, it's having a couple of volunteers that would be comfortable with effectively going through the process, deciding if we ultimately wanted to go for a direct award, which we're allowed to do so under the contract, and our current auditors are part of that, or if we wanted to go out and do a full test of the market. And I put within the overarching paper, there is an issue with the external audit market that has got tighter and tighter over the course of the last couple of years. So thinking through those options, having some governors to go through those and just decide what we want to look at in terms of the next process is going to be quite key to that. I also think there's going to be an increase in cost coming with this, and that's linked to the fact that we've had significantly more the requirement for the review that external auditors need to do has increased year on year, and is now, I would say, they have to put in quite a lot of work, and that's resulted in an increase in cost across the board, not just for our local ones. So the last time we effectively went out to appoint external auditors, we did it jointly with SLAM. And when we did that, there were 2 governors from SLAM and 2 governors from Oxley's that were involved within the process to determine exactly how we went through. We went for a full, I believe that was a full, went out to the market to see who would be interested in coming along and becoming our external auditors. And just in terms of the details that people know broadly who was involved last time, it was Raymond Sheehy and Richard Dimmond, who was the lead governor at the time, who were involved. So what we're looking for is somebody that ideally has had some experience of being on an audit committee or finance, or actually some of the governance processes or some other interactions with the external auditors or with auditors in general. But I think we would widen that out because we recognise that not necessarily everybody on the Governor Committee would have had that access, but it's really somebody that would be comfortable stepping through a specification process and then the procurement process, plus giving the Audit Committee some advice. Usually the whole of that process is supported. I would be on there, SAT, DINSA and our procurement people would be on there, and Sally Bryden would be on there. The auditors usually also provide some input in terms of, I mean, they don't audit, as Abby had said, the quality accounts, but they do have a look at our overarching governance structure. They do quite a lot of work on value for money. So all of those aspects are going to be covered off when they actually effectively come in and audit. So that's hopefully giving you a little bit of a feel for the type of individuals that we're looking for. We don't necessarily need to be restricted, by the way, to 2 governors, should the governors feel that they want to come in mop-handed and come and help us with this particular process. We've got some hands up, which I don't know, Andy, if you want me to take or if you want to.
Yeah, you manage it, Azra, please.
Okay, fab. In which case, let me just double check who put their hand up first.
Sally.
And it was Sally and then Sue.
Sally had her hand up first, yeah.
Thanks. Just really wanted to reiterate that the finance team, Joe and I, Steve, we'd all be there to support people to talk through on the technical side of things. Obviously recognise that the Council of Governors is a group of lay people, so but because the external audit is the appointment of the Council of Governors, we very much want you to be part of the process and to feel that you've had an opportunity to really understand all the different issues. So I think it's a really good opportunity to get into the meat of a particular role of the Council of Governors, and it is time limited, but to say that there would be support there for you through it, so don't get put off by the technicalities. Thanks.
Sue?
Yeah, hi, just a question. You mentioned that obviously last time you did this, you did a full review of what was out there, and you've just said that you think that market has reduced somewhat at the moment. Is that correct?
That is correct. So there's a couple of organisations that have already gone out for external audit, and they actually did not have anybody that came forward to bid for the work. So it may still be advisable to go out and see what the market looks like. Just because there will be that increase of cost, I'm fairly certain the costs will go up from what we're currently receiving. And as Steve had said, we did have a very good bid from Grant Thornton that was extremely competitive the last time that we appointed. So it's really deciding, before we make that final decision to go out to market, we want to discuss this clearly with the governors, is do we want to consider a direct award? Because I have offline, because of the issue that we had around the market, had a conversation with Grant Thornton to say, should we go out for going out to market? Would they actually put in a bid? And I did have at the time confirmed that they would put in a bid. So we would have at least one. It's whether or not we'd actually be able to test the market with another competitor that came in to bid.
I wanted, just this is an outside chance, but do we know what other trusts or which companies other trusts are doing to see if it's worth looking at what they think of what they're getting, or would they not share that information?
I mean, I think regularly, the reason I know that the market is restricted is there's a group of directors of finance and chief finance officers. It was probably about a year ago that a number of them went, and there was a huge amount of conversation across the sector and the fact that they simply did not get anybody that was applying. SLAM currently use Grant Thornton as well, because it was a joint appointment at the time. And as of this year, so this year-end audit, they're going to be audited by exactly the same partner as us. Previous to that, they had a different partner and a different team. Now, they may have a different team, but for the first time, the partner will be the same. And just to highlight, the partner that we've just had a recent change in partner, and I would say both the partner and the senior manager on the role have changed this year-end. So it's going to feel almost like a refreshed team that's doing the external audit.
Okay, thanks for that, Azra. It's just interesting, isn't it? I suppose it's the challenges of whether you have someone you know and continue working with them because they know the organisation, you know them, or whether there's any benefit at all for going to a whole new organisation. Swings and roundabouts on it, isn't there, really? Thank you.
You're welcome, Sue. Jessica?
Hi, good afternoon. Thank you very much. I just wanted to check how much time commitment is needed for this.
So I would say in the piece at the beginning, we would be saying, okay, well, which route are we going down? I think we could probably cover that off, and Steve can come in if he disagrees. I think that's probably would be able to be covered off quite easily within an hour. What we would then normally do is we would do the specification, and we would effectively pull that together for the governors in terms of, okay, this is the specification of what we're going to go out with. The governors would then, whoever was going to be on the panel, would then need to review that specification, check and see if they wanted any tweaks. And then we would go out to tender, which would all be dealt with by the procurement department. The governors wouldn't need to be involved within that section. And they would then have to be present if we had multiple bidders, or actually even if we had one, to effectively go through those bids. That might be a couple of hours, and I would say detailing the specification, it's probably just reading it. I don't know if we would necessarily need to come together, but if we did, again, no more than an hour. So an hour to decide if we're going to go out for full, all-blown bid, an hour for looking through the paperwork, which we'd circulate beforehand to say this is going to be how we're going to run the bid and the scoring mechanism, because that's really important when you do it. And then probably about 2 hours, I would suggest, because I'm not expecting a huge number of bidders, broadly that amount of time.
Thank you.
Stephen there, Azra.
Steve?
Yeah, just Azra perfectly summarised. That's exactly the situation. I would agree with that, and certainly I think that first meeting, which is deciding on the options going forward, is the crucial one in the short term. And as you very rightly say, an hour would do it.
Excellent, thank you. Any more on that, Azra or Stephen?
Other than wanting to see a slew of names being putting themselves forward to join that particular meeting, that was it on that item.
You'll have to have a selection process, no doubt, Azra. Anyway, well done. Thanks ever so much. We come now to any other business, and we did have a question that John put in. John, do you just want to go over that question before we ask for an answer?
Thanks, Andy. It was again one of the sort of, I guess, opportunities that the trust invited us as governors to attend, and it was the London Safety in Mental Health Settings Group, which was about 2 weeks ago, and their focus for that particular seminar or webinar really was about trauma-informed care models. And the trust that were invited to present their model on that day was Camden and Islington, and it was very informative. And you know, I thought to myself, wonder how is this evolving within Oxley's generally, because I can feel it from the national as well as the local interest that trauma-informed care models are, I guess, going up the agenda.
Thank you, John. Jane, got Abby.
Thank you very much, Andy. And I suppose the simple answer to your question, John, is yes, that we are looking at trauma-informed care. And you asked for examples. We started in our female wards, Avery ward now. This is probably about 3 or 4 years ago. And this is something that's also being trialled in our community mental health team. So yes, we are doing it, and we have had presentations back to our acute care forum around how this has gone on the female wards, and then it's sort of been spread to our other inpatient wards, and it will be spread to our community mental health teams. I don't know whether Jane wants to add to that.
Yeah, it's a really good question, and Oxley's are well in the lead in terms of the London Cavendish Square Group trusts around this area. We're one of the 4 trusts that piloted the CTHINK Act, Relational Security Trauma Informed Care, and Naidu, our head of nursing, is now one of the London facilitators. So we're also part of the South London Mental Health Innovation Network, and this is looking at particular safety programs in mental health using QI methodologies and co-design. But one of the key projects for the 3-year programme is the London Safety in Mental Health Settings, and this is what Naidu has been part of. And there's 3 strands to this. So there's a CTHINK Act, which is where our teams have undergone quite intensive multi-professional training around the framework. And this is for acute wards and our PICU. But it's also about leading safely, where there'll be development training for leaders around attitudes and behaviours to create a safety culture on the wards. And this is quite interesting. Naidu's very much involved in the role modelling of that leadership. And then the third area, as you've already picked up on, is the communities of practice. And if you want to have a look on the OX, there's actually a presentation on the reducing restrictive practice area, which is Naidu and Emma Hopkins actually doing a presentation on what they've applied and learned, and you can see how they've used the knowledge base around the relational security to deliver trauma-informed care, and they give some really good case examples. It's a brilliant piece of work. So we're doing quite a lot, John.
Thank you very much. Yeah, you did respond the next day with some of the examples on the slide. So thank you very much. But it was an interesting discussion as well. That's what alerted me to the question.
Thanks, John. Great question, and thanks for those responses. Any other business from anybody else? I haven't had anything else notified. If I can't see you, can you sing out, please?
You've got Suzanne, Shale, and Neil.
Oh, sorry.
Yeah.
Sorry, Suzanne, please.
I just wanted to add an example to the ones which have already been given by John, because it might be an area that people wouldn't automatically think about. But the visits that I've been doing to prisons over the last period that over the period that I've been in NED, it's been really interesting hearing them talk about trauma-informed care, which is really significant because so many people who come into prison and are receiving mental health care, in the prison system, have had extremely traumatic lives and very, very difficult childhoods. And it's been, I was very struck when I went to HMP ISIS in London that the governor there is very focused on taking a trauma-informed approach throughout the prison, and our staff are working actively on that. But it's not unique to them. I mean, the other place where I was really struck by it was in the women's open prison in Kent, where they recognised that most of the women who are there have had been engaged in extremely abusive relationships, both as children and then later on as adults. And so the way in which they work with those women is very much orientated towards overcoming some of the issues that's caused for them. So I think that it might not be the place that you'd immediately think of, but I think it's really interesting that it's taken root in such an important way in our prison healthcare.
Yeah, thank you, Suzanne. John, was that an old hand?
No, Andy, it's a very different topic. But if it's okay to raise another question, please, and yeah. It's just an observation. When I've thinking of the last 3 meetings I think we've not had a single serious incident report. And I was thinking, is that a really good indicator, or has it been sort of a change of, I guess, criteria?
I'll let you hand over to Jane, but we're keen that the Council of Governors do see our serious incidents. Jane, please.
Yeah, there is one serious incident. It's due to come here, but it can't come at the moment because it's still confidential due to criminal inquiries that are going on. So that will come in due course. I think we're actually up to date with the ones that have been here now. So I don't want to tempt fate, but we haven't missed any.
Thanks, Jane. Now we're very keen that I think these really matter. I'm not saying it just as we do it, but I think it's really important the Council of Governors see these things. They are very important, and we will continue to bring them back. If there's nothing else from anybody else, just want to thank you all for your attendance today. I thought it was a really good meeting, some great questions, and I want to thank all the staff at Oxley's for in really great work during some very, very challenging times. So thank you all for everything you do. Thank you for our governors for, as I say, for a really good meeting. Thank you to my fellow Neds for the huge amount of work that you do as well. So if there's nothing else for anybody else, I'd like to say thank you very much and goodbye. Thank you.